just to give it now. Yeah.
Hello, my name is Dr. Midgley, and I'm going to talk you through how to complete Chart 3 of the MAAR Chart Injectable Medicine Suite version 4. And this is the crisis or emergency and regular injections authorisation and administration chart. This is the chart which is more rarely used, but it has a real place in patient care. So we're going to look at why you might want to complete this one and how you do it. Just to highlight some key governance points around completing this document correctly. This has been highlighted in the other clips on how to write a PRN and syringe pump MAARS charts. And I'm just going to highlight some key issues on the left-hand side of this A4 sheet that Pan London has developed for authorisers and people administering these medicines. So just to say that there are some go-to places to get symptom control advice if you need it, and we've also got a separate clip on good go-to places. When you are writing your drug, never use a dash when you're talking ranges. Always write TO, because a dash has been misinterpreted as a dot before in handwritten forms. They really need you to write 2 rather than dash. And notice how I've written here morphine 5 milligrams to 10 milligrams in that range. Please do write milligrams or micrograms each time, so that it's very clear that this is 5 milligrams to 10 milligrams, especially important when the chart is handwritten. Any drug where you want to authorise less than 1 milligram should be written in micrograms with the word micrograms in full, for example here. But if the drug is 1 milligram or more, you should be writing milligrams, as in here. Okay. So onto the chart itself. So the top part of the chart looks very similar to other charts in the suite. You can see that you can enter your palliative care team contact details, always really valuable, because it means the person on the scene at the time of crisis has got a go-to phone number for advice and support if they need it. You need to mark when another chart is in use, for example, syringe pump, patch, enema, and you need to complete your name and your GMC or NMC or GPHC number. Please do document allergies and be aware that this chart is simply for emergency medication and also regular intramuscular injections to do with palliative care. The chart itself, if I just enlarge the relevant bits. So the top bit focuses on what to do in a crisis or an emergency situation that might need subcutaneous or intramuscular intervention with a palliative care drug. There's really only 2 scenarios when you'll be completing this bit of the form. Scenario 1 is if the patient is at risk of having seizures. Scenario 2 is if the patient is at risk of having a massive bleed. With scenario 1, I've written what we always write in the hospice. If they are at risk of having a seizure, safety net them. The drug we choose is Midazolam. The dose is 5 milligrams to 10 milligrams IM, because it's a bit quicker than subcut in this situation. And the maximum 24-hour dose is liberal, it's large, because they may be subject to seizures that are difficult to control, and the frequency is narrower than the frequency for agitation and distress. But there's large hemorrhage, again, same drug, same dose ranges, same dose, same route, and same liberal expansion, because really role in scenario 1 seizures is to stop the seizures. Role in scenario 2 is to get the patient unaware of the bleed that they're suffering. with large hemorrhages, they're likely to be arterial and the patient's likely to die very quickly. But if there is somebody who can administer drugs on the scene, then they want to administer large doses quickly to render the person comfortable, not distressed and unconscious. I've highlighted that. If I just expand the when would you ever write a regular dose of medications, the only scenario when you might be wanting to write something up for a palliative care patient for something regularly is if they are steroid dependent. The steroid is valuable for symptom control, and if they're unable to manage it orally now, for example, in the case of brain tumour, where steroid has been really helpful for management of difficult headache. You would then use this chart to authorise the use of dexamethasone subcut instead of orally. There's a conversion ratio, so 3.3 milligrams is equivalent to 4 milligrams of oral dexamethasone. So this person is on 6.6 milligram once daily subcut. I've forgotten to write subcut. And that's equivalent to 8 milligrams of dexamethasone. This is probably the largest volume you can give because it's a 2 ml injection. And notice that I had to write the time that I want the patient to have it. So 10 a.m. But again, that is, it's rarely used, and it's most patients who are on steroids at end of life actually don't need them parenterally, but occasionally it's critical for good symptom control. If you're not sure what to authorise, do ring the hospice or your local palliative care team for advice and support, and never spill on to the next page, because the next page is unusable because it doesn't have any demographics on it. And finally, to make this authorisation valid, you need to ensure a valid signature. It can be a wet signature. Usually that's what you'd use if you were completing this chart in a patient's home. You just must remember to complete your GMC, NMC or GPHC number and put your name in capital letters as well on the top right hand side. And you just need to sign against each drug that you've authorised as well. And then normally that hand completed chart could be just left in the home. But if you are for some reason doing it from a distance, you will want to then scan in and send the form to the relevant health professionals involved in care. In which case, if you're going to do that, you must send it from your own personal nhs.net or equivalent email. It mustn't go from a generic address or it won't be valid. You can send it to a generic address, and please copy in your broader practice or your broader district nurse base, because if the recipient notices something wrong, they need to be able to get back to somebody who can correct quickly. So they would need to do a reply to all. And if you're gone from your desk, you just simply wouldn't get it. So it needs to go to reply to all. What's much more normal now would be to complete from a distance in your surgery or at the district nurse base electronically, in which case you don't need to print and add a wet signature. It's enough to simply print, ensure that you put your GMC or other number in the right place on the top right hand side, and make sure that you have printed and dated against each drug that you've authorised. And that is the electronic signature. The last step is it must go from your own personal email address to the recipient. It mustn't go from a generic address, just as per the wet signature. And please CC in your practice or your district nurse base so the recipient can reply to all if there's something wrong. And that is it.